Good evening, everybody. Lee Yap is my name. I'm one of the new consultants in Waterford, consultant urologists. And today I'm going to be talking to you a little bit about testicular cancer. So just a little bit of background in regards to who I am. Well, I did postgraduate medicine at University of Limerick. I came through the Irish training system, through the Royal College of Surgeons, and I did a master's then in Healthcare Informatics at UCD before going on a fellowship out to sunny Brisbane, and just returned back earlier on this year. I'm currently a consultant with the UPMC group in Whitfield and Auteven. I have a public appointment in University Hospital Waterford. I'm also affiliated with FRCS and University College Cork. So recently back from Australia, like I said, out in Australia, I was working in the Princess Alexandra Hospital, which is the largest tertiary referral centre in Queensland. I was involved in kidney transplant, as well as complex kidney cancers, testicular cancers, which I'm obviously talking about today. And I trained also in robotic surgery for prostate cancer. So into testicular cancer in Ireland. Well, we have about 175 cases per year in Ireland, and that equates to about 7 men per 100,000. It is about 1% of all male cancers is made up with testicular cancer, so not hugely common. It's more than 90% are what are called germ cell tumors, which I'll talk to you a little bit more about in a few minutes. 34 is the average age at diagnosis, but the age range, as you'll see, is anywhere from teenagers right up to elderly men. 1 to 2% can be bilateral, involving both of the testicles. But the good news is there's over 95% 10-year survival rate with testicular cancer, so high cure rates. Well, what are the risk factors for testicular cancer? One of the main risk factors is an undescended testicle. And the aim really for boys who have an undescended testicle is to bring it down into the scrotum, ideally at a younger age, between 18 months and 2 years is what the guidelines would recommend. And certainly if you can bring it down before the age of 10 years old, some of the research suggests that that will negate your testicular cancer risk later on in life. If you have a history of testicular cancer, you have a 5 to 10% chance of having a tumor on the other testicle at some stage in your life. If you are white and born in Northern Europe, unfortunately, you have a higher incidence of testicular cancer, particularly in places like Norway and Denmark. If you have a family history of testicular cancer, either a brother or a father, your chances of testicular cancer go up by about 6 or 8 times. And also infertility or subfertility is a risk factor for this type of cancer. And we often see men have subfertility who come and present with testicular cancer. So really, self-examination is a key point to finding these cancers early. And I guess one of the main take-home messages is really to get to know your body and get to know your normal anatomy. And we would recommend starting self-examination from early adulthood let's say in your mid-teens. And it involves examining yourself ideally in the shower when it's nice warm water. The testicles tend to hang lower in the scrotum, and you can get a good feel of your anatomy, your testes inside the scrotum. And just to run through then some of the normal anatomy, you have a cord at the back of the testicle, which carries the blood supply, the nerves, and the lymphatics. There is a separate little tube known as the vas deferens, and that carries the sperm from the testicle up to the ejaculatory duct. Often it can feel like a kind of firm piece of cooked pasta at the back of the testicle. You have what's called the epididymis, which is the tubular system at the back of the or top of the testicle here. This is made up of tiny little tube system, and if you actually stretch that out, that would measure about 250 meters, which is really impressive. And the sperm travels down through that tube before it comes into the vas deferens. Often feeling the epididymis can be mistaken for a mass or a tumor on the testicle. but these generally feel kind of moderately firm and usually separate to the actual testicle itself. And when we talk about testicular cancer, it's really here in the body of the testicle that we're most likely to find a testicular cancer. And this is where your seminiferous tubules, or the structure involved in making your sperm, is stored. And often, if you find a tumor, it'll feel like a hard mass growing on this part of the testicle. So what should you do if you find a lump? Well, really, you need to go see your GP urgently. This is not something that you want to sit around and wait to see if it goes away. You need to go present to your GP. They'll often examine you and then refer you for an ultrasound if they think you need one. And they'll often then as well refer you on to a urologist. If you haven't had an ultrasound done by the time you see us, we'll arrange for one to be done. We'll also take a blood test for what are called tumor markers. You'll have a staging scan performed if we feel that there's a cancer there, which is a CAT scan, and we scan your chest, your abdomen, and your pelvis, looking for any signs of cancer gone outside of your testicle. And we may end up booking you there for an urgent operation to remove the primary site of the tumor, which would be one of the testicles. At the clinic, we would often also talk about sperm banking, which is an option to deposit a sample of semen to be frozen for fertility later on after your treatment. So, well, what does an ultrasound scan involve? It's usually done by an ultrasonographer in a private room, and they usually takes approximately 10 minutes to perform the scan. It's painless. They put some jelly on the scrotum and place a probe on and run the probe over the testicles, looking for any mass or abnormality inside the testicle. There's no radiation involved, so don't worry in that respect. It uses acoustic sound waves to pick up a picture, and there's very, very good accuracy rates with an ultrasound. So if there's anything in there that shouldn't be in there, the ultrasound should find it. Tumor markers, as I mentioned, are proteins or enzymes secreted by tumor cells and found in the blood. So it's a simple blood test performed either in the clinic or at the phlebotomy department. And we use these tumor markers to help with the staging of a testicular cancer. It can also help in us predicting what type of tumor we might find. After your treatment, then it's help used in monitoring your disease and whether any signs of it coming back. And it's also used in the prognosis as to depending on how high your tumor markers are at the time of diagnosis. So testicular cancers, the majority, 95%, are called germ cell tumors, and these can be broken down into two different types, either seminomas or non-seminomas. The seminomas are usually in the older gentlemen, approximately 30 to 50 years old is the risk group for these particular tumors. They're usually slower growing, but they're very chemo and radio sensitive, which means they respond very well to chemotherapy and radiation treatment. There is a relapse rate. About a fifth of patients will have a relapse or a recurrence after treatment. The non-seminomas are found more in younger males. It can be anywhere from late teens up to mid-30s. There are several different subtypes, and depending on which subtype, they can be more or less aggressive. These tumors themselves are, again, highly chemosensitive, so they respond very well to chemotherapy. About a third of patients with these non-seminomas will have disease outside of the testicle at the time of presentation. And about 30%, unfortunately, again, will relapse usually within the first year. So again, this is the age distribution for seminomas and non-seminomas. You can see the blue, the non-seminomas more in the younger population, and the seminomas usually found in the slightly older population, kind of 30 to 50 age bracket, as I mentioned. In regards to mortality, well, our mortality rates have gone down over the last number of decades. the actual rate of testicular cancer has increased, but the mortality rate has decreased. And that's probably due to better screening, better access to imaging, better awareness, and better chemotherapy drugs, which came on in the mid-70s. And there are very, very good survival rates with testicular cancer. This is the 5-year survival data. So regardless of whether you have a seminoma or a non-seminoma, the survival rate, certainly at 5 years, is in the high 90s. And even at 10 years out, your survival rates are going to be in the mid to high 90s. So when we talk about staging for testicular cancer, there are 3 stages of cancer. The majority of patients, about 60%, will present with stage 1 disease. And that is when the tumor is confined to the testicle and hasn't spread anywhere else outside of the body. Stage 2 is when cancer cells have spread through the lymphatic system, which is the drainage system of the body. And that drains into a compartment called the retroperitoneum, which is where your big blood vessels called your aorta and your vena cava are, and tumor deposits can grow there in that compartment. And then we have stage 3 disease, which is more advanced, and that is when we have solid organ disease. And that's when disease is found either in the liver, the lungs, and sometimes even the brain. So the operations that we would perform for testicular cancer are really two operations. The first one is to remove the primary location of the tumor, and that's in the testicle. That's done as a day case. It's called a radical orchidectomy. So we not only remove the testicle, but we also remove the cord right up to the incision site in the groin. At the time of doing the surgery, we would discuss inserting a prosthesis, which is either a silicone or a saline-filled artificial testicle, which we can insert. And that's what they look like there. And we would size match those to match the other testicle. Patients recover very well after this, and we would just recommend not doing any heavy lifting for about 6 weeks. The other operation that we perform is what's called a retroperitoneal lymph node dissection. And that's a big operation, and it's to remove that tissue that deposits in the retroperitoneum, which I mentioned a few minutes ago. So we have to move the bowels out of the way and get into that compartment and resect out that mass. And about a quarter of patients after they've finished their chemotherapy will need to go on and have this type of operation done. I guess the main long-term side effect, unfortunately, with this operation is it can affect men's ejaculation. And that's simply because the nerves that are responsible for ejaculation run down in the area where we're going to be dissecting out that mass. And when testicular cancer spreads, it spreads through the lymphatics, as I mentioned. Some subtypes can spread through the blood system, but the majority of them spread through the lymphatic system, which is the drainage system of the body. So how does this impact on fertility for men with testicular cancer? Well, as I mentioned, there is the opportunity to sperm bank, and this doesn't necessarily have to be done right before we remove the testicle. It can be done after the operation as well. A UK study showed that only a quarter of men actually avail of the opportunity to sperm bank. And it's something that I would highly recommend to patients prior to any operation for removing a testicle. But even with that, men at the time of diagnosis often have an element of subfertility. Some studies suggest even up to a quarter of men have no sperm seen in their ejaculate at the time of diagnosis, and up to half of men actually might have a low sperm count. So those men are unfortunately already on the back foot when it comes to fertility, and they would benefit then from sperm banking. So if you undergo chemotherapy, it does affect your sperm production. That usually is delayed at about 3 months after your chemotherapy, that you might start seeing your sperm count start to drop. But any treatment-induced infertility can recover, and usually recovers 2 years post-treatment. But unfortunately, this is for some men, it can impact on the window of when they might have been planning to have a family. And some guidelines would recommend that you shouldn't start trying to have a family until 12 months after you've finished your cancer therapy. So, combine those together. That could be 3 years of a time frame before you can get back to starting a family. So what are my take-home messages from this presentation? Really get to know your anatomy. Check yourself in the shower regularly. Make sure if you have any young boy in the family, make sure that their testicles are down. This is part of the postnatal checks, but sometimes they can retract later on, even after they've done their postnatal checks. So if you have a small boy, just make sure next time you're bathing them to make sure both testicles are down in the scrotum. Don't delay in seeking help. If you do find some abnormality, don't dig your head in the sand like some men do with their medical issues. Go and see somebody, see your GP and get it sorted. Remember, there are high cure rates for testicular cancer, regardless of what stage you're at, stage 1, stage 2, stage 3. It's very chemosensitive and very good long-term prognoses. And for those men who find themselves in the unfortunate position with testicular cancer, do consider sperm banking. That is done up in the Harry unit in the Rotunda Hospital. So we will refer you up there and they would provide this service for free, and they would freeze your sperm for a period of time for free. And that really buys you time then and gives you peace of mind when it comes to starting a family, regardless of the outcome of your treatment. Okay, that's all from me, guys. I hope you got something from that talk, and I hope you enjoy the rest of the evening, and take care. Good night.
Okay, Mr. Yap, so we've got a couple of questions here, so we'll get started with our first one. Do I need to have testosterone replacement if I have a testicle removed? From Brian there.
So usually not is the answer to that. About 5 to 10% of patients who end up having a testicle removed may require some hormone replacement therapy with testosterone. For the small percentage of men that would have bilateral disease and in the unfortunate situation where they might have both testicles removed, those men almost certainly would require some testosterone replacement. But usually for men who have one testicle removed, only about 5 to 10%. And usually we only treat men who have low levels and are symptomatic. And there's various different ways we can deliver testosterone now. Testosterone gels, which you can rub into your skin, or more conveniently, there are injections which you can give every 10 to 12 weeks to replace your testosterone.
Okay, I just want to go to Kieran's question there, just from the earlier Q&A. So Kieran asked, I've had 2 PSA test 6 weeks apart. Both levels have been 3.8. Should I be worried? My age is 54.
Okay, well, thanks for your question, Kieran. So at 54, ideally your PSA should be less than 3. Your GP has done the right thing in getting 2 separate PSA checks, at least 6 weeks apart. So you would meet the criteria to be referred on to see someone like myself in a urology clinic. And from there, we would arrange for an MRI scan of your prostate. And the MRI scan gives us 2 key pieces of information. The first thing, it'll give us your prostate volume, and we can work out what's called a PSA density, which is the relationship of the size of your prostate to your PSA level. And the bigger the prostate, usually the more allowance we have for a higher PSA level, which is still benign or non-cancerous. And the other very important thing that it'll tell us is what's called a PIRAD score. And that's basically a risk score that our radiologists will assign to your prostate as to whether they think there could be a prostate cancer in there. And the score goes from a low risk at number 1 up to a high risk at 5. And certainly if you have a score of 3, 4, or 5, the next step after that would be a biopsy of the prostate to sample some tissue from the prostate. So certainly I would not be panicking, but you do meet the criteria to be referred on and see someone like myself at a urology clinic.
And I suppose from a urology perspective with prostate, diagnosis, the MRI has become a real go-to for urologists, and we here in UPMC, we do MRI prostate, and we have consultant radiologists who specifically report on the prostate MRI scan. So there's no radiation involved in MRI, which is really important from a consultant prescribing a diagnostic, but also to have that specialist report on the scan, which feeds into yourselves then in the urology department.
Absolutely, absolutely.
Okay, so just we have another question in there. Does a varicocele increase the risk of testicular cancer?
So a varicocele does not increase your risk of testicular cancer. Varicoceles are quite common, actually. About 20% of men walking around will have a varicocele, usually on the left-hand side. A lot of them would be subclinical, so you may not be able to you may not have any symptoms from it, and some of them will only be picked up on an ultrasound test. The thing that a varicocele can affect, however, is fertility, because it alters the temperature of the testicle, and semen production happens at an ideal temperature, which is outside your normal body temperature, and that's why the testicles can move up and down depending on how warm you are. It's really to optimize that temperature for semen production. So the varicocele, which is veins in or around the testicle, can alter the temperature. So certainly if you're having some difficulty getting pregnant, or some issues around fertility, we would often then repair those to try and restore the sperm production in that testicle.
Okay. Pat has a question there. Could you clarify further relationship between undescended testate and testicular cancer?
Yeah, so it's probably the one main, I guess, modifiable risk factor, or something that you can do something about. You know, you can't change where your race, you can't change kind of where you were brought up, but the undescended testicle is probably the most modifiable thing that you can ensure to make sure both testicles are down in the scrotum. So about 10% of men, 10% of cancers that we find, they'll have a history of an undescended testicle. And the main thing is that it's brought down early. The ideal age for a young infant to have their testicle brought down from the groin, if it hasn't come down naturally, is about 18 months to 2 years. The risk then increases, but if you bring it down certainly before the age of 10, some of the data would suggest that then will negate your risk going forward of having testicular cancer. So for men, let's say, or for teenage boys who come and present, or men even later on in life, and they end up coming to our clinics, we still would bring it down into the scrotum. And the main advantage of doing that for them, it doesn't reduce their risk at that stage in their life, but it allows them to self-examine properly, to feel that testicle, and they'll know if there's any abnormality from being able to access it and feel it.
Okay, thank you. And is there any complications of having a testicular prosthesis?
Yeah, so the complication rate would be very low for a prosthesis. They're made with either saline, which is salt water, or silicone. They can be put in either at the time of the operation, or even down the line. If the man has changed his mind and wants one inserted, we can put it in after his primary surgery, and even after his treatment. I guess the main issues that can occur with the prosthesis, the main thing would be an infection. So if you got an infection around the prosthesis, you may require a course of antibiotics, and the prosthesis may have to be removed. That can sometimes delay follow-on treatment if you need a chemotherapy, if you require that after a diagnosis of testicular cancer, which is not ideal. And traditionally, some people previously would have thought that we wouldn't put one in until they're finished all their treatment. But we know the risk of infection is very, very low, so we'd still offer it at the time of surgery. And the other thing that can happen is they can migrate a little bit, particularly in the first few weeks or few months after they've been inserted. Sometimes it can go up towards the groin, so you might have to milk it back down into a good position, and that can be a bit bothersome for some men. But overall, very, very low rates of complications with the prosthesis.
Okay. Look, thank you very much, Mr. Yap, for taking our questions this evening and for your presentation.